In our fifth and final section, now we will talk about the malignant tumor of oropharynx. The malignant tumors of the tongue, tonsil and tonsillar fossa. Then we have tumors of the fascial arch and pharyngeal wall, and then the parapharyngeal tumors. All these are the structures present in the oropharynx. So we will discuss about the all the tumors involving these structures. So carcinoma of the posterior 1/3 or base of the tongue. Base of the tongue is present in the oropharynx. So the base of the tongue, this is the back 1/3 of the tongue. Posterior 1/3 or base of the tongue. It can be local, lymphatic, distant metastasis. So the spread of the carcinoma of the posterior 1/3 or base of the tongue can be local, it can be locally present, or it can spread by lymphatic system or by distant metastasis. The diagnosis of the carcinoma of posterior 1/3 of the tongue is by laryngoscopy, CT scan, and by biopsy. All these are very important tests for the diagnosis. Treatment of the carcinoma of the tongue is radiotherapy, chemotherapy, and by the surgery. So it can be local by lymphatic or by distant metastasis. Diagnosis by CT, MRI, biopsy, laryngoscopy, and treatment is by the chemotherapy, radiotherapy, and surgery. Carcinoma of the tonsil and the tonsillar fossa. This is the tonsil here. So the carcinoma of the tonsil. Most common and present as an ulcerated lesion with necrotic base. There is ulceration present and the base is necrotic or makeup of the tissue that is dead or necrosed. Persistent sore throat. Whenever there is even tonsillitis or involvement or infection or inflammation of the tonsils, sore throat is very common. So in this carcinoma of the tonsils also, there is sore throat. But it's persistent, not getting better. Difficulty in swallowing, pain in the ear or lump in the throat or neck, bleeding from the mouth, fetor, oris, and trismus. Trismus is the locked jaw and the tonsils. This whole area is involved. There is involvement of the temporomandibular joint also, and this can cause the locked jaw and the trismus. And fetor, oris is foul smelling. The mouth is, there is foul smell coming out of the oral cavity. Then carcinoma of the fascial palatine arch. It's superficially spreading and well differentiated with late tendency for nodal metastasis. So this fascial arch tumor or carcinoma of the palate or palatine arch is the superficial spreading tumor, and this tumor or carcinoma has well differentiated cells. So far by now we all know very well that if the cells are well differentiated, not poorly differentiated, the prognosis is very good, treatment is effective. So again, this tumor, it spread late because the cells are well differentiated and there is late metastasis, late nodal metastasis. Spread may occur locally to contagious structure or lymph nodes. So it can spread to the surrounding area and the lymph nodes. Upper deep cervical and submandibular nodes may be involved. So the spread is to the cervical and submandibular lymph node present below the mandible. Sore throat, local pain or earache is present. So as with the carcinoma of the tonsil or the tonsillar fossa, there is sore throat, persistent sore throat. With this type of carcinoma also there is pain, sore throat and the earache. Treatment is by radiation or surgical excision. Then carcinoma of the posterior and lateral pharyngeal wall. Lesions remain asymptomatic for a long time. So asymptomatic is present, no signs, symptoms are produced for a long time with the carcinoma of the posterior and lateral pharyngeal wall. Treatment is irradiation or radiation therapy and surgical excision of growth with screen grafting. Combined with block dissection when nodes are palpable. If nodes are palpable or enlarged, the block dissection or nodal removal is done. Lateral pharyngotomy with or without mandibular osteotomy. Pharyngotomy or opening of the pharynx is done to remove the carcinoma, can be with maxillary mandibular osteotomy or opening of the mandible. So this is carcinoma of the posterior and lateral pharyngeal wall. Next, parapharyngeal tumors. Para is around, so area around the pharynx. Parapharyngeal tumors cause a bulge in the lateral pharyngeal wall of oropharynx. So if it's around, it will definitely, when it grows and become bigger, it causes bulging of the pharyngeal wall. Distort the pillars and soft palate. Mimic neoplasm of oropharynx. The common type of parapharyngeal tumors are the deep lobe of parotid gland, neurogenic neurolymoma, chemodectoma, lipoma or aneurysm of internal carotid artery. These are all the parapharyngeal tumors which are present in around the pharynx. We have the tumor involving the parotid gland, we have neurogenic type of tumor, and then we have chemodectoma, lipoma or aneurysm of internal carotid artery. Styalgia eagle syndrome. Due to elongated styloid process, so styalgia or eagle syndrome, there is elongation of the styloid process or calcification of stylohyoid ligament. Pain in tonsillar fossa and upper neck which radiates to the ipsilateral or the same side ear. Aggravated on swallowing. Diagnosis of eagle syndrome is by transoral palpation of the styloid process in the tonsillar fossa radiograph. Treatment is by excision through transoral or cervical approach. So styalgia is due to elongation of the styloid process or calcification of stylohyoid ligament. There is pain in the tonsillar fossa and upper neck which radiates to the ipsilateral ear on the said side, aggravated when patients swallow or eat. So these are all the tumors which are present in the areas around the oropharynx, including the tongue, especially the posterior 1/3 of the tongue, and then we have the tonsil, tonsillar fossa, lateral and posterior pharyngeal wall, and then parapharyngeal carcinomas. This was all about our topic, in which we discussed in detail about the benign and malignant tumors of the nasopharynx and oropharynx. Thank you for watching sqadia.com.